Welcome to the Ortho on the Go podcast. My name is Chuck Dowell, host of the podcast. This is an educational orthopedic podcast focused on discussing both clinical and functional orthopedics. We will discuss a variety of topics within the field of orthopedics, including reviewing interesting cases, hearing from different professionals throughout the orthopedic profession, and discussing common musculoskeletal injuries and complaints. This podcast is meant for anyone that wants a better understanding of orthopedics, including all levels of practitioners, coaches, parents, and athletes themselves. Welcome back, everybody, to the podcast. Today, I have the pleasure of speaking with Tessa Kothe, our Dr. Tessa Kothe. She has her doctorate in physical therapy from UW-Madison, you said?
UW-Milwaukee.
UW-Milwaukee, sorry, for all those UW-Milwaukee people. And then a bachelor's in exercise science, correct?
Yeah, and that's from UW-Madison.
Excellent. And then also CrossFit Level 1 certified. She's the owner and operator of Summit Physio and Performance here in the local Colorado area. So I thought it'd be good to have Tessa on the podcast to discuss low back complaints. Tessa actually treated me. I have two previous back surgeries, L5S1 discectomies performed, and occasionally have some lower back issues. I went to Tessa when I was having kind of a flare-up of my SI joint or kind of lumbosacral area, and she helped me kind of get through that and see some deficits that I had. And I thought it'd be fun to have her on the podcast to kind of talk about common low back complaints and what we can do regarding this. So welcome to the podcast.
Thanks for having me, Chuck.
So, we were just having this conversation prior to starting things. I think, me being a PA and an athletic trainer and you being a physical therapist, I think it's important that we work together regarding a lot of these low back complaints, because most of these complaints can get better with mobilization, and conservative measures. What are the more common things that you see in your clinic regarding patients that come in with kind of acute or chronic low back complaints?
Yeah, I'd say the most common thing I'm seeing is because my clinic is direct access, I get to see people that are pretty acute injuries, and I can get people in the clinic pretty quick. So I see a lot of acute strains at the back where they were just doing a squat or deadlift or some sort of movement or whatever it was in the gym, or even just I bent over and my back went out basically. So I see a lot of that kind of thing. And then I also see a lot of chronic back issues of people that have seen multiple providers and need a fresh perspective and a really thorough evaluation. And so I kind of see a wide range of acute to chronic back issues. Most often low back, but I do see a lot of TL junction, which is kind of that intersection between the lumbar and thoracic area. Would be another area I do see from time to time.
Yeah, I think, there's, in my mind, when I see patients in clinic, I think there's two typical presentations, like you said. There's the either I bent over to pick something up and I immediately felt pain in my back. And there's the, hey, I've had this back pain off and on. It tends to hurt when I do certain activities. As you said, your practice is inside a CrossFit facility. So majority of the patients you probably see are kind of these higher level athletes, but also seeing just, the regular everyday low back pain as well. What is your thought process when evaluating these patients? Because I know my thought process changes a little bit depending upon the mechanism of injury or the kind of the chronicity of the presentation, if that makes sense.
Yeah, absolutely. So I always start off with using a body chart and mapping out the client's symptoms. And then what we do is we kind of get into symptom behavior. So we're what makes it better, worse? What is the intensity of the pain? Does it travel anywhere? And then I try to map out, are there any other areas of pain you've ever had, or history of injuries and things? And then that subjective exam typically will guide what I'm going to do with them objectively and what I'm going to test. So usually after that first 5 to 10 minutes of chatting with them and mapping everything out, I have a pretty good idea of how I want to evaluate that client. If someone's walking in the door and they're I'm 9 out of 10 pain, I am really, really hurting. I'm not going to assess a lot of things because I'm just going to flare them up in almost everything. And then all those tests are maybe even some false positives because they're just, everything's painful. But if someone comes in and they're like, I only have pain when I'm squatting above 200 pounds, well, that's a whole different story. I'm going to be like really diving in, super thorough assessment, kind of testing a lot more than I would in someone in an acute situation. So it really depends on like that irritability level is like the first and foremost thing that guides my assessment. And then kind of what things they're telling me. Like if they're telling me like I have pain going down past my like glute or butt, then I'm likely going to do a little bit of a neurological screen and see what's going on there. And if they're having like radicular numbness and tingling symptoms, we're going to be more thorough in that area. Or if they're more localized, then we'll kind of not necessarily need to go that route. That's kind of a lot of my thought process when someone walks in the door.
Yeah, I love it. Yeah, I think our thought processes are very similar. And like I said, with the athletic training background I have, I kind of think more functional oftentimes when I'm examining patients. But as you said, if somebody comes in with an acute onset of low back pain, they're 9 out of 10 or 10 out of 10 pain. Your straight leg rate tests, a lot of your tests that you're going to do that are going to put them in these provocative positions are probably going to be false positives because essentially everything's going to hurt. And really my answer, and it sounds like you're in a similar thought process, is let's calm your acute inflammatory symptoms down. Let's get your symptoms to settle down. And then maybe we can get a more functional examination of you and see if there's something that we find on examination that's, reproducible that we could correct that prevent this pain from coming back in the future. What are some of the modalities you can do? I think one of the things we often get asked in my clinic when patients come and see me in the orthopedic urgent care is when should I start physical therapy? And what's your kind of thought process behind that? Should we start right away? Should we give it 3 days with heat and kind of, modified activities? What's your thought process?
Yeah. Well, I am kind of probably a little biased in this area, but I typically do recommend people kind of seek out some care as soon as possible, because there's a lot of things we can do in that acute pain situation. So first and foremost, we can kind of guide like what exercise are like very tolerable, which is like a 0 to 3 out of 10 pain. So I'm often kind of trying to figure out that first day of like, okay, what are exercises that are very minimal pain? And we can have you do these often to at least get some gentle movement through there, maybe some isometrics through the back or the core. And then things we can do right away that really decrease pain is, I'd say dry needling is probably one of my best tools I can do that can really, really calm symptoms down. It really depends on like where we're going to go, like with the location of dry needling, but like in the low back instance, you can go directly at the area. But sometimes we don't want to go like right at ground zero. We'll maybe go a few segments above or below to get some muscles pumping. Or we can even go like a little bit loose depending on if things are referring down. But that's probably one of my best things that like if people can get dry needling, and even just some soft tissue works and gentle like grade 1, 2 mobilizations that can help quite a bit in that very acute onset.
Yeah, I feel like dry needling has kind of been a game changer for multiple reasons. Because it's kind of a modality that you can do that can help this acute soft tissue, muscle spasm type pain. And I'll often send patients, to you guys, and I don't like to, necessarily, most of our prescriptions are evaluate and treat and then modalities as necessary. But I think in this acute situation, the dry needling, the more manual work is quite helpful for these patients to calm their acute inflammatory symptoms down. And then, as you said, maybe then you can get a more functional evaluation once those acute symptoms are settled down.
Yeah.
Go ahead.
Oh, I was just gonna say, the cool thing too about dry needling, and a lot of my training with dry needling is dry needling with addition of electrical stimulation. There are specific like settings we can do. So an alternating current is like most supported for pain relief. We can also do something that's more of like a neuromuscular if someone's going to have some strength benefits we want to get at. And then you can also do like recovery dry needling, which is swelling management, or like delayed onset muscle soreness, like DOMS management. So that's a cool thing too. Like the drenulane I'm probably mostly referring to is it with E-stim and either a pain relief or like a swelling type protocol. Because if someone comes in with like acute, really swollen ankle sprain, and really swollen knee, I'm going to probably do a bit more of a recovery protocol and then target some muscles that really have a big muscle pumping effect to help with improving that lymphatic system.
I love that. It's yeah, my athletic training, in the training room stuff has been quite a few years ago, and I remember we used to do, e-stim for a lot of these acute patients and iontophoresis and phonophoresis type stuff. But now, that things have advanced, you guys have those modalities which act as a similar way, but I think are much more effective. So that's amazing that you can do those types of things acutely on the patients. What if, let's say, somebody's listening to this at home and we just kind of had this conversation, heat versus ice, mobility versus, lying on the couch and are in bed for a couple of days and doing nothing. What is your kind of thought process as far as, hey, I bent over to pick, let's say, my kid or something up. I had this acute onset of low back pain. What are you recommending that first 72 hours if they don't necessarily want to come see you in clinic? What are home things that they can potentially do?
Yeah, so even if like someone was just like reaching out, like, hey, I'm not sure what to do, I'll usually kind of ask them a few questions. And in the area of back pain, I'm gonna say like, I try to screen out like, does it feel really way worse if you bend forward or bending backward? So I kind of try to see if they have any sort of directional preference at all, because that can cue me in of like maybe I can give them like one or two exercises that will be tolerable for them. And then I'm usually telling them like, let's see if you can find some sort of movement that feels okay and like is not causing that pain to go above a 3. So we're trying to find like a couple things that keeps the pain pretty low and they can still move through some movements, because gentle movement is going to just help flush out like local inflammation and just kind of help from things really stiffening up, because things can just start to stiffen up if you just lay around. And so the other thing that's like supported, if people can tolerate some sort of cardiovascular thing, if it's like a bike or even just walking fast, something like that, like getting systemic circulation going can also be really helpful. So it kind of depends on the person, but I'm usually asking them a few questions of like how we can figure out a few things that I can give them that they can try for exercises that will be tolerable for them.
Yeah, I completely agree with you. And I think it's the same way when friends, family, or people reach out, it's, do a screening to see if there's any red flag symptoms, radicular pain, neuropathic type pain that's more constant, causing any weakness that may require, imaging. And then, as we talked about before, we kind of started this, I'm more of a heat than an ice, especially on the low back, because most of the literature shows it wants blood flow to that area, wants movement to the area. I'm always recommending they get up at least once an hour and do some light exercise or light movement. Similar to the DOMS, you always kind of feel better if you're up and moving and getting blood flow to the area versus just staying stagnant and causing, increased, lactic acid buildup and or stiffness within the area. So I think the movement's quite helpful for a lot of the patients, although it seems counterintuitive and they don't want to do it. I think it will help them in the long term.
Yeah, absolutely. Yeah, I think going the heat route is typically the way to go for the back in these cases, and frequent movement is definitely preferred over just even like once per day.
Yeah, and like you said, I think these low back pains, especially the acute low back pains, kind of present in a typical fashion where that first kind of 3 to 5 days are most painful. And so just kind of calming their inflammatory symptoms down, using the heat, using the movement, using some light stretching activities, like you said, maybe some light exercise, maybe not even weight bearing. They could do an exercise bike or something like that, like you said, just to get that systemic blood flow to the area. And then if by day 5 or day 7, those things settle down, as you've mentioned, you can maybe do more of an exercise or kind of a light stretching activities, more functional type testing to see if there's anything that potentially you can improve at that point. And I often just recommend the simple, cat, camel, and bird dogs, and just, light stretching exercises just to keep the mobility within the area.
Yeah, and we're often like looking at the hips as well. I find so many clients with back pain have a lot of like hip weakness, inherent hip weakness. So that's like a big area too that I'll be looking at, especially in someone that's not as acute, of like where, some a little bit more root contributing factors of like, yeah, we don't have outer hip strength, we don't have hip extension strength, limited. We may have some like nerve tension going on, even if they're not having some leg pain. So there's definitely a lot of factors that can contribute to like why people have recurrent issues too.
Definitely. And, something I feel like I've seen a lot, and maybe you've seen this as well, is how much do you think this SI joint kind of plays into these acute onset of low back pain? I think a lot of these patients have this kind of lower L5S1 SI, gluteal radicular type symptoms when they have these acute pains. And, some believe that there is some mobility within that SI joint that can be manipulated or that can be kind of thrown out of position that can cause the muscle spasms to happen. How often are you seeing that? And how much do you think that plays
Yeah,
into these patients presenting?
that's a really good question. I'm probably on the more school of thought where I think the SI joint is it's moving very little. I will do my SI joint cluster special tests. So usually if like the first two tests I do, which are a thigh thrust and a distraction test, if those are two are negative, I'm not really going down to test a ton more of those unless there's other things that are like cueing me into that. But I often find that people think their SI is like the main issue, but then they're like, then when they point to like their symptoms, they're like way up into their lumbar, or they're it just not like adding up in the clinical exam. So I find that like there's more issues with like hip weakness than just like local SI. Like if I were to kind of stress test that joint, that's just kind of my clinical background and my experience with SI. I think it can be really tough, but on that, like really always trying to like make sure that SI is a perfect alignment. I really think that's like detrimental to the client and having this like mindset of like, oh my gosh, if things are not 100% perfectly aligned, I'm going to be in pain. Because that's not necessarily the case. It doesn't really add up clinically.
Yeah, I feel like we get a lot of patients that come in that say, "Oh, I have one leg longer than the other," and I've been told this by multiple physicians, and this is leading to my symptoms. And I think naturally we all have that, so that's not always a key factor into playing to the role of why that's causing the low back pain. And so maybe, and we'll add to this, but maybe you can add a video of some exercises that we can put on for people that are watching that they can do for more of this acute low back pain. Just simple kind of stretching and mobility type exercises. Tessa was kind enough to provide us with a video that she shot in her clinic for the podcast for exercises that individuals can do for lower back pain, especially the acute lower back pain. I've included that into the YouTube video. So if you'd like to see those exercises, you can listen to the podcast on YouTube and or just go to the end of the video and see the exercises that Tessa filmed for this. Please join us next week and or at the next podcast for the second part of this series when I have a discussion with Tessa regarding chronic low back pain and how we can diagnose this, treat this, especially in our higher level athletes and individuals that maybe have some functional abnormalities causing this chronic low back pain. Again, thank you for listening to the podcast. Please follow us on social media, both Instagram and Facebook. And please feel free to reach out regarding any topics you'd like to hear covered or possible conversations you'd like for me to discuss. Thank you again.